All right, good evening, everybody. I'd like to call the Community Mental Health Program and Budget meeting for April 11th to order. Before we start, I'd like to read our mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. With that, I'll take a motion to adopt the agenda. Support. Motion by Commissioner Birdie, support from Commissioner Nagovan. All in favor signify by saying aye. Aye. All opposed? All right. Next up is the hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Anybody from the public? Going once? Going twice? All right. Seeing none, we will close the hearing of the public. Next is other agenda items, which is now when I turn the microphone over to John.
Thank you. Nice seeing everybody tonight. I felt it was prudent, even though we didn't have any action items for the board, given the times and the opportunities and the challenges that we have within community mental health. It was prudent to our public and our stakeholders to have a meeting and to discuss and continually be mindful of our finances and our system of care as we move forward through 2018. So I have a number of items that I'd like to talk about, a couple more pieces of paper I want to pass around. And while I'm doing so, first I want to draw your attention to this banner that was put up just a few minutes ago as our continuing ongoing outreach to the public to make ourselves more transparent to those who may need services. Our marketing folks went out and were able to purchase so far a few of these banners, and we want to put them in high traffic, high public areas, arenas throughout Macomb County to draw everybody's attention to what we do relative to delivery of services with community mental health. Those things that we have pride in: person-centered planning, quality of consumer care, evidence-based practices, family-focused services, and care coordination. And then below that, it also speaks to the service populations that we actually serve. So it's a good advertising and marketing effort. I would be interested in hearing from the board, and maybe Lynn or Barb obviously take some notes on where you suggest maybe some of these should be placed. They're very portable. We can leave them in one spot for 30, 60 days, whatever, and we can move them someplace else. I have 5 right now, and we certainly can pick up another 5, 10, 15 more of these. They're not cheap, but they're affordable, and we could place them wherever the board may have an interest. We are thinking about the Macomb Clinton Township Library. Obviously, 3 of the local Department of Health and Human Services sites where many of our consumers come and get enrolled for Medicaid, perhaps in the administration lobby downstairs, and I'll be curious to hear what you suggest as other places where we may want to put those.
Brian?
I mean, for a start, I would think maybe the city halls, start at the bigger cities, and then if that works really well for helping out, go to the other cities because of the cost factor of it, because there's always residents in Macomb County going throughout the city halls for a number of different reasons.
Joan?
I'll take one at City Hall, Warren City Hall, but first it'll have to be approved. Not by the board here, but by the mayor. I'm sure every mayor will have to approve it. But if they approved you for a TV ad, then I guess they'll approve that.
Linda?
I'll see if we can put one in the YMCA.
Kathy?
I think all those are all good ideas, and perhaps just even on a, as John had said before, 30, 60-day rotation even, because I think if it stays in the same place for a long time, people get used to seeing it. If it's moved around, it'll, I think, attract people's attention, their eye more. And it can be all the libraries, all the local municipal offices at various points in time. High traffic, yes. And perhaps even some of the doctor's office, the clinics that, like Henry Ford Macomb Clinic, I'm thinking of the 23 Mile, the place where I go, but there's many of them around, urgent care places.
Any other suggestions? What about, yeah, Partridge Creek? What about Macomb Community College? Both campuses, maybe?
How about Freedom Hill?
Freedom Hill?
They're vinyl and aluminum, so they're very much weatherproof. Probably not windproof, but
For Freedom Hill, there might be a way to get them to put it up as a community service thing and actually put it up bigger, like they got for the sponsors on the side, all the way across. They might be able to do it for community service if we talk to them.
okay. Anyone else? Thank you. If you have any other suggestions, send me an email. What I'll do is I'll take a picture of this. We already have a picture of this. I'll send it to you, and you may be able to use it if you're going to go approach somebody and say this is what it is. I'll send it to you in an email. Then on the other items for the agenda tonight, I wanted to spend a period of time that we can talk publicly about our Internal Services Fund, our ISF, our Medicaid, and I passed around a document just for the board, just kind of a follow along, if you will, document. And you have all the attachments. You have hard copies. You know, it was interesting after the last full board meeting, everybody went on Easter vacation, and there was only a short period of time between the last board meeting and in program and budget here, so there were no action items. And but like I said, nonetheless, I felt we should meet. And I did provide you in an email for your prior review of the items I wanted to talk about tonight, as well as you have a paper copy too, so there's nothing electronically for you to follow along on. What I do want to bring to your attention again is the first document is the Macomb County Community Mental Health ISF. It's that yellow document, or the document with the yellow font on it. Looks like this. Now you've seen this before, and you know, should you have any questions or comments, stop me along the way. You've seen this before, and if you follow along on this one page that I passed out to, my talking points, this is our Internal Services Fund executive brief. And, you know, as you know, we can continue to pay keen attention to our finances and our Internal Services Fund, where we start and where we're going to finish each year as part of our risk management of our contract. So there's 3 pages here, and I'm just going to speak to the first page first, and then later on I'm going to come back and speak to the third page, which is general fund, and that's later on in our agenda. But on the first page, this is your typical, and you've seen it not too many months ago, this is your typical executive brief for the Medicaid and Healthy Michigan combined Internal Services Fund, and then our budgets at large. So we've already indicated to you, and I'm not going to go through all of this other than this is, you look at the third column over, fiscal year 16-17, those are our actuals. And I think we should continually pay attention to that, and I can break it down into more line items and more categories if you wish to see that. But this is our actual expenditures for fiscal year 16-17 that closed out last October or September 30th. So we actually had in total revenue $183 million. I'm sorry, $174 million in total revenue. And then in total expenses was $183 million. Everybody sees that right there? We actually overspent around $9.7 million. Our fund balance at the end of last year, starting on October 1st, was $5.6 million. Okay, and that's all Healthy Michigan money sitting there. And then we received that $5 million from the legislature in the way of a grant that was appropriated in the fiscal year 2018 budget. So again, as a reminder, we have $10.6 million approximately. The number is going to change a little bit. $10.6 million in internal services fund starting October 1st. We should have, as you know, closer to $12.6 million. So in the last 5, 6, 7, 8, 9 years, we've always been fully funded in our ISF. This year, we're not fully funded. Our financial picture looks much better than it did last year, and I'll explain that. But you also need to know that Macomb, like other PIHPs, I think Southwest Behavioral Health in the very southwest corner of the state, they're fully funded in ISF. The rest of the PIHPs are not fully funded to start this fiscal year. And so there's a pattern that's going on here. And this is important too as we start to close out on the budget, as we start to and we go into a conference here in a couple of weeks, how our voices continue to be heard, but we can come back and talk about that later. So the the current position is that our internal services fund is not fully funded this year, and we're about $2 million shy. That being said, last year if you're following along, and I'll take questions, if you have any comment along the way. Last year we were $25 million upside down. We were going to go through all of our general fund, and we were going to overspend and go into the county's risk or into the state's risk corridor. That didn't happen. That's if we stood flat-footed and didn't do anything, but that didn't happen. We did an awful lot to affect changes to be able to correct our revenue to expenses. So this year it looks much better. This year we actually are showing, if you go over to the third quarter, or the fourth column there, it shows that our revenue is $168 million. It shows our expenses, $164 million. So that's a positive revenue to expense of $4.9 million. So that's a whole lot different than we were last year. There's some concern on whether that number will stick, and that's why we're talking tonight. There's a number of variables and a number of ways we can make that number become better and hopefully not project out in a worse situation when the end of the year rolls around. So right now we're looking at just shy of $5 million in revenue to expenses. That's a favorable position to be in, even though we're not fully funded in our ISO. If everything works out favorable this year on our revenue to expenses, and just as we stand right now, we should, have $15 million again. Yep.
Linda?
Does this take into consideration the DAB losses?
No, we're going to talk about that.
Okay.
It does take into consideration DAB right now.
Nick?
DAB in this,
The current budget reflects the DAB loss in there, but if we can recover DAB dollars, then that'll be added in too. I'm going to talk about that in a minute.
okay, thanks. And then not the fifth, you said we lost, sorry, Nick. So we lost, last time you reported that we were reduced, there was just a new thing that we were reduced by a certain percentage, 17%, or, so does it account for that too?
I think you're referring to the general fund.
That's general, that was
Yeah,
general
we're going to talk
fund.
about that
Okay.
a little bit. Yeah.
Go ahead, Nick.
John, I'm not sure I understood one thing. Does the 10 million include the 5 million, or is the 5 million in addition to the 10 million?
The 5.6 and the 5 million totals the 10.6 there. It includes that.
Okay, so we're still 2 million technically short,
Right.
even with the 5 million.
Correct.
Gotcha.
But this year we've done a lot. We've done an awful lot, and we've talked about that. Utilization management of community living supports, and we'll talk about that some more yet tonight. Utilization management of acute inpatient, staffing resources, holding provider rates firm, those types of things. So I think we've been pretty successful so far, with a lot of collateral damage perhaps along the way, but we've been real successful so far in being able to be solvent in the way of our PIHP contract, so in our PIHP budget. So right now we're looking favorable towards having a fully funded ISF at the end of the year if this rings true as it does. And I'm not certain it will. And I can't say right now if it will ring favorably true or if, we could see added costs and expenses and then all of a sudden our ISF starts to slip backwards. So that's still a possibility. We'll know more if you look back on this page here. So I'm really done with this document for a few minutes here.
Hold on, John. We got Linda and then Lou.
Nick's question prompted this next one from me. We have two 5 million figures that we've been working with, and one is the 5 million that the legislature gave us. The other was the placeholder from the Medicaid or from something, Healthy Michigan.
Yep.
So are those the two that's still in place? The placeholder is still there, is in the 10 million? So, okay. So we didn't have any. It was from the legislature and money moved over from Medicaid to give us the 10 million
From the legislature and money moved over from Healthy Michigan.
from Healthy Michigan. Wow, okay.
Lou?
Personally, it just bothers me that on paper, you're 2 million short. Hello? Okay. If you ever had to spend the ISF in a critical situation, you're at least $7 million short because you're balancing it on paper and you can't use the Healthy Michigan ISF. So, I mean, who are we kidding? The State Department has utilized this strategy because my assumption is they show some of these numbers to the feds and theoretically they're not picking up on this paper balance, John, but it's not reasonable. You look at two PIHPs who this week I downloaded stuff from, Holland, the newspaper, that they're in danger of losing their contract because they're zero ISF, and I imagine they have a Healthy Michigan ISF that they can't apply. So, at some point, there ought to be an asterisk, you know what I'm saying? I mean, who are we kidding when we say we're 2 million short when theoretically you're at least 7 million short? So, when we say how much better this year looks compared to last year, we shouldn't be kidding ourselves. I mean, if the State Department wants to kid the world, I guess there's nothing we can do about that, but the realism is that if you can get the 7.5 million that's theoretically promised us, then maybe your ISF would be close to being fulfilled. But it's at least 7 million short or more for what that's worth, and we ought to stop saying we're in such good shape when we can't spend that other money that on paper says we're 2 million short. I think that's an inappropriate public position because one of these days somebody's going to say spend it, and then you're going to be awfully embarrassed when we say we can't.
That piece has been moving for the last couple years because first it was you don't go dare near the Healthy Michigan dollars. You couldn't commingle the funds. I think much of where the state was at, the state was trying to get clarification from CMS on the appropriate financial recording and tracking of those dollars. And so some of the staff, we did a deeper dive into the contract, and even though the state continues to merge more so that you can use those Healthy Michigan dollars, the contract, the fiscal year 2018 contract, it reads kind of tricky. It says the PIHP fiscal, and I'm reading it verbatim here, right from page 68 of the contract under risk corridor. It says the PIHP financial responsibility for liabilities for costs between 100 and 110% is to be paid from the PIHP's ISF. We know that. for any cost overruns. The ISF balance shall be tracked by Medicaid and Healthy Michigan funds contributed. Each portion of the ISF shall retain its character as Medicaid or Healthy Michigan funds, but it may be used for risk financing across the Medicaid and Healthy Michigan programs. And then the last line reads, Medicaid ISF amounts may be used for Medicaid or Healthy Michigan cost overruns into the risk corridor, and Healthy Michigan ISF amounts may be used for Medicaid or Healthy Michigan cost overruns in the risk corridor. There's an awful lot of words in there. So they want you to hold those, what was the term that they used? Retain their own character, but they're also saying that they're allowed to be used as cost overruns. I don't think anybody's tested it yet. We haven't tested it yet. I said we haven't tested that yet. We haven't gone into the risk corridor to have to test that yet.
They hurt us consistently by moving Medicaid consumers into Healthy Michigan and cut the reimbursements. That's number one. And then they come up with voodoo accounting by saying take the Healthy Michigan ISF and apply it to your Medicaid ISF operation, and on paper it looks like you're balanced. With the left hand, they hurt us financially, and they attempt to cover it on paper with this other move. Now, if what you said is true, then Lakeshore should not be in trouble, because I'm sure that Lakeshore can apply their Healthy Michigan to ISF, and Lakeshore is on the record as saying they have a 0 ISF, and the state of Michigan is now going to, what would be the word, opt out of the contract with Lakeshore, and I'll bet you $50 what's going to show up the Monday after they do that is with a health care physical organization taking the place of Lakeshore, which will be a privatization on the shores of Lake Michigan, and that's exactly what's going to happen on the west side of the state. Because if what you just said is true, then Jeff should be able to apply that ISF to cover that because it's a Medicaid expense. But if he does, he'll do 5 years at Leavenworth. So, I mean, it's crazy. I'm just saying, for what it's worth, we ought to be honest about the numbers, period. And as I said, maybe an asterisk might go a long way toward indicating where we are. And I'm merely saying, between you and I, we're not 2 million short, we're at least 7 or 8 short. Okay. But that's not the picture we're putting forward. And if we had to apply it, we're a lot shorter than $2 million in the application. And yet people who would read this would say, where did that money go that you're not saying you can apply? Because they won't understand it, because the public position that we keep putting forward is our ISF is only 2 million short of being fully funded. Fully funded means able to be applied, and that's not true. I don't want to beat it to death. It just bothers me because that's not the public image that we're putting out there. We ought to be careful about it, because one of these days we're going to be held accountable for these numbers, and somebody's going to say, who took the money that you said was there, and now you're saying it's not? We need to be careful about it. That's all, for what it's worth.
Nick?
Am I next?
Yep.
Yeah. The difference between Healthy Michigan and Medicaid, well, let me first ask one question, and that's that what I think I'm hearing you say is we have a deficit in regular Medicaid and a surplus in Healthy Michigan. And then, is that right? And then I heard Lou suggest that we were moving people from Medicaid, or that the state was moving people from Medicaid to Healthy Michigan. Healthy Michigan isn't eligible to somebody who's eligible for regular Medicaid, the expansion, under the federal law, because there's a different reimbursement rate, right? Is that correct? Are they doing it anyway? Yes. And how are they doing that? Because other than, I understand the DAB, I finally figured out the DAB piece after reading 37 different things 5 different ways, and it finally penetrated the skull. But what I'm not clear on is how you move people from Medicaid to Healthy Michigan. The federal government would be ballistic over that because Medicaid is reimbursed at 50 to 60%, wherever we are at this point in time based on the unemployment rate, and Healthy Michigan is reimbursed at 90% by the federal government. That's why the Medicaid expansion law said it could only cover people who weren't eligible under the regular Michigan program. Plus, the separation between Medicaid and Healthy Michigan, other than that factor, is a state creation, in that they created, rather than expanding Medicaid, which is what the federal government authorized, they got a waiver to create a separate program. Otherwise, it would simply be an expansion of Medicaid. So I hear what you're saying about the confusion. As I read the letter from the Department of Health and Human Services to Lakeshore, their complaint was not whether or not there was a Healthy Michigan surplus that could be moved into the ISF, and wasn't, but rather that they conditioned their ISF on contributions from the independent CMHSPs, from the CMHSPs. Now, we're the same thing here, so it's not an issue. But there, they said our ISF is, if we go into surplus, we will bill to the constituent CMHSPs, and then the CMHSPs told the state, no, they aren't getting it from us. I mean, I think that's a big, I mean, I don't know who was telling who what, but I would have assumed that Lakeshore would have gone to the CMHs first to get the commitment, just as we would have gone to the county to get a commitment, for instance, which is one of the options, which we haven't exercised because county doesn't want to take on that liability, and I understand that. But that theoretically is one of the, if we said, well, the county will pick it up and never talk to the county, you know, then the county said, no, we never committed to that, then obviously your risk plan doesn't make sense, so they have to come up with something else. So I guess my question is Lou right that they had a Healthy Michigan surplus in Lakeshore or not? And secondly, I think you're right, you're correct. If they're saying we can put it into the ISF, then it's hard to argue that you can't use it for a deficit on either side. But if you have to keep the money separate, then there's arguments both ways. I guess the question I have then is there any attempt to get that clarified through either the state or the federal government?
You bring up a lot of really good points that we should talk about more. Across a number of different fronts. Relative. I don't know what Lakeshore's financial situation is, whether it was related. Part of this is related to the DABs, and we can talk about the DABs. But you have an understanding of what's going on with the DABs. Certainly have an understanding of what's going on with Lakeshore relative to the PIHP asking the CMHSPs to cover the risk, the ISF. I don't believe that the CMHSPs are going to the counties to ask for a match or their share. Right. It's the CMH.
They just said they weren't going to cover it.
Yeah, the CMHSPs just have to knuckle down and trim services and supports to be able to come up with their portion. That's the only way they're going to come up with that. We can go back to the department, have them interpret this for us further or give us further guidance on it, but it does, clearly speak to the fact that the Medicaid and the Healthy Michigan need to retain its character, but it also allows the opportunity, as I indicated, and we're saying the same things over a couple of times, that you can use them to cover your whole ISF, and then if you overrun either on Medicaid or a Healthy Michigan plan, you can use those dollars.
Now, explain to me how how people who are Medicaid eligible are being enrolled in Healthy Michigan, because that's a disqualifier for Healthy Michigan.
Okay, let me get right to that, okay? So if you running down the sheet here, so we talked about the ISF, and so I'm going to put that document away for a while. We talked about that. The mid-year status, the next time we're going to see a new updated report, we need to pay attention to this and pay attention to these dollars. You don't want to end up like Lakeshore. We'll be on May 31st. That's when we submit that to the department. So you'll see the next update in June. It's a little bit creates anxiety that you can't find out your next report, until May 31st. They're labor intensive to be able to do an FSR. The third quarter FSR or ISF. I put ISF. I really meant to put FSR in there. The third quarter FSR is on August 15th of this year. Then there's an interim FSR report that's due on November 10th. And then the final is due next February. So if you just scratch out ISF and put FSR in each one of those. So we talked about the ISF from Medicaid, ISF from Healthy Michigan Plan, and the fact that there's a legislative grant in there, $5 million. I'm following on this one sheet that I put together. We talked about the ISF is not fully funded, that there's a positive revenue to expense projection, and so there's a question mark after that. If we continue to do our due diligence, there will be and expected to be a positive revenue to expense projection in stability of our finances. The next thing, Nick, then is to your question, is DAB migration recovery. We don't enroll the people into Medicaid. Department of Health and Human Services does that. So they go into CHAMPS. Everybody, as I understand it, everybody who's on Medicaid every year, they need to re-enroll in Medicaid. They fill out the application through the DHS office. It goes into CHAMPS, which is their electronic eligibility file. And the way it has been working in 16 and 17 is that there's the disabled, aged, and blind, and we talked about this at the legislative breakfast too. You get about $263 per member per month, disabled, aged, and blind. Healthy Michigan Plan, I think you get about $40. I don't know the number off the top of my head. $40 per member per month. And then the TANF, the Temporary Assistance to Needy Families, you get, I think, between $8 and $16 per member per month. So when those folks are re-enrolling in the electronic CHAMP system, it is taken the DAB people and moving them into HMP. And that's the point of contention, that if a consumer has severe enough conditions, and we've sent all these encounter reportings in to the department to say, look, they're DAB, they're not HMP. HMP, as you know, is a different program. They're DAB. So if they're DAB today and their Medicaid is re-enrolled for tomorrow, they should be DAB tomorrow. And they're not. They're being re-enrolled. Many of them, not all, but many of them are being re-enrolled into Healthy Michigan Plan and or TANF, and only over the course of perhaps 6, 8, 10 months do they reclaim their DAB enrollment. And so statewide, it has cost us $100 million. The PHPs, they did an analysis, not through Milliman, through, Jim, who did they use? Yeah, the PHPs, I can't think right off the top of my head. So they did an analysis, and throughout all the PHPs, it's a $100 million loss. And so I think we projected 16, 17, and projected for 18, we will lose about $8.1 million in DAB migration loss.
And if I can?
Nick?
Now, and my understanding is that the legislature is considering, I think one of the subcommittees reported, a partial restoration of that money, but it's like a third of the total, which is better than nothing, but at least it's something. Is that correct?
My understanding, at one time, they were gonna give up about 30 million statewide,
30.
but I hear that that doesn't have the life it had once before, but
Well, I just read something recently, I think one of the subcommittees reported, I don't remember if it was the House or Senate, that included that 30 million. But yeah, I mean, that's all speculation until we get through the revenue estimating conference and the final conference committees. The migration of DAB to Healthy Michigan, a DAB person by definition a DAB person by definition, I think is Medicaid eligible, right?
correct.
So putting them in Healthy Michigan, you got two problems. Healthy Michigan assumes you've got a mixture of people who are healthy and not healthy. DAB, you got people who are, by definition, not healthy. So the federal requirement that the programs be actuarially funded, by moving a DAB person to a Healthy Michigan program, doesn't that violate the federal regs? Because you can't put a Medicaid person in Healthy Michigan under federal law. If the state, through its program, is taking somebody who is eligible for Medicaid and enrolling them in Healthy Michigan instead of Medicaid, you got a problem, they've got a problem, and maybe the computer's programmed wrong. We saw that with unemployment compensation, where the program was saying everybody was fraudulent, and turns out they weren't. But it sounds to me like there's an internal problem at the state on either the programming of the computer or the way they're analyzing it, because you can't put somebody from Medicaid into Healthy Michigan. They should be putting them into Medicaid.
Well, correct. A new consumer coming through, you can get them HMP enrolled, by 5 o'clock every day. To be a new
Unless they're
consumer,
Medicaid enrolled.
HMP, you can get them enrolled if they've never had Medicaid before. It's my understanding that within the day's time, 8 hours, you can have them enrolled in Healthy Michigan plan the way the new system works. A DAB consumer takes about 10 months to become DAB. You just can't roll straight into DAB.
What about, and Medicaid takes how long? Probably 30 days or more.
Well, it's retroactive to the date of eligibility, but HMP is a Medicaid program. I mean,
Is DAB retroactive?
any of those will be retroactive to the date of to the date of application. Yeah.
To the date of application.
Once if they're determined eligible, it's retroactive to the date of eligibility.
Okay. I think I see what's happening. Thank you.
So, I'm sorry.
Lou and then Kathy.
I just want to mention that there's a bottom line that nobody is talking about. When Healthy Michigan was established, the principle was if you are on Medicaid, you are not eligible for Healthy Michigan, period. And if you are Medicaid eligible, you are not eligible for Healthy Michigan, period. And what the state is doing is taking the Medicaid folks who have to renew annually their situation and putting them in Healthy Michigan and cutting the reimbursements directly to the PIHPs. Clearly, that's an absolute violation of the law. Now, who's making out? The State Department is not dispersing the dollars appropriated by the legislature. They're keeping the money, and to use a cruel expression, they're skimming the approach. The legislature theoretically made the appropriation when they approved the budget situation, but the state isn't dispersing it. And on top of that, they're putting Medicaid and Medicaid eligible into Healthy Michigan, which is the lowest reimbursement to the PIHP, and they're keeping that differential money in Lansing. and I don't know what they're doing with it, but they even argued about the $100 million loss statewide on the DAB situation that John mentioned. And they're reluctant about even a $30 million, which would be a 1/3 cut. So, 16 PIHPs took a $100 million cut. They're going to get 1/3 of that money. So if that were to pass, our $8.5 million would be about $2.5 million, maybe. So we're still on the short end of that compensation situation. But the point is, they're violating the law under which Healthy Michigan was established, and nobody's saying a thing about it. I take that back. The state association, Bob Sheehan and Al, have been singing that song in the halls of the Capitol until they're hoarse. But the State Department has dug in their heels and won't comply with it. I don't know how that's happening. To me, the legislature is the defining voice here, and they're just absolutely ignoring it. In the meantime, we come up with these crazy numbers that we may be called responsible for downstream. And I'm saying we ought to be more appropriately reporting our public image. And I'm concerned that these numbers, in a sense, don't do that. And I don't mean that as a criticism. We are reporting within the parameters that the State Department says we should report. What I'm saying is those parameters are false, because when the challenge happens, you can't apply the numbers that says you have a fulfilled ISF, which is part of this whole thing. And that's part of Lakeshore's problem. I'm sure they have an ISF under Healthy Michigan, and they can't apply it. Although on paper, maybe it's a couple of $1 million. But Jeff has reported back as 0. Now that's impossible if you have a Healthy Michigan group. It's impossible not to have a number on paper. His problem is he can't apply it. So for what that's worth, it's singing a song that's ridiculous.
Kathy?
Thank you. I don't think we know what Lakeshore is actually reporting, and it really doesn't matter. It's irrelevant to what we're talking about right now. But I asked this question in a different setting, and I thought I understood the answer at the time, but now I don't again. So I'm going to ask the question in this setting. I thought that Healthy Michigan is Medicaid expansion. Is that? And then I thought Medicaid expansion means people whose income is in the 100% to 133,
From 33 to 100.
percent. So how could somebody who then, and Medicaid is 100% and below?
No.
No?
Medicaid is 33% and below.
Oh, Medicaid is also at 33%?
No,
133?
Medicaid's at 33% and below. Healthy Michigan is the people between 33 or 35% and 133% of
Right.
poverty.
So then, regardless of where the levels are, if you have a certain, why aren't you in it based on whatever your household income is? Why isn't that where you're placed? I don't understand how they would take it and put it in another place when their household income wouldn't comply with that.
Well, Medicaid also has an assets test, and Healthy Michigan doesn't. But we're all getting, I think we're all getting to the same problem, which is that the state's computer is classifying people wrong somewhere along the line. And so the question is, how do you solve that? Because as John pointed out, we don't say you're Medicaid and you're Healthy Michigan. The state does that through CHAMP's computer system. My question, John, is have we asked our federal representatives to look into this? And I say that for two reasons. Number one, not only is the State Department shortchanging us, but they're overcharging the federal government. because of the difference in reimbursement rate. And secondly, because when the fiasco occurred with the computerization of unemployment compensation, the state didn't fix that until Congressman Levin got involved, and at that point, the federal government came in and said, you can't be doing this. So my question is, have we discussed this at all, or maybe this is really a question for the state association, because they should be discussing it with the federal delegation as well.
You know, I can't answer, where the association is. I haven't heard any reference to the association talking with the federal delegation. I do know there's been, numerous meetings, as well as we've been involved with some of our lobbyist efforts to partner with Washtenaw and Ottawa County, because we all use GCSI, to bring it to the attention of our state legislature. So I don't think there's any absence of understanding of what's going on state-wise. I can't answer the question on the federal side. Other than Congressman Levin knows about it, because he was in he heard it one time.
Mr. Chair,
Go ahead, Kathy.
just to follow up.
Yep.
Now, I remember Nick said that the Healthy Michigan doesn't have the assets qualification. You have $1 million. It's just based on your household income. But that's new to me, that Medicaid is only up to 33% of poverty rate? How do you, what is the income qualification for Medicaid? Do you know? What, based on the percent of, or is it not based on the percent of the poverty level? I'm asking John. Do you know? Or does staff know?
Well, there's individual and family, and there's thresholds. The individual is maybe $9,000, family.
No, I'm not asking the dollar amounts. Did you know the percent of the poverty?
Well, Medicaid is up to 100% of federal poverty level, and then HMP.
Yeah, that's what I thought.
HMP is 100 to 133%, and Nick mentioned that earlier.
No, I thought, okay,
It was 35.
I'm confused because I thought he said it was lower. So it's 100, 0 to 100% is Medicaid. That was my understanding. Okay, well, we need some clarification there, but it sounds like it really doesn't matter because people at Health and Human Services, they're just plopping them wherever they feel like it. So, okay, thank you. You can continue, Mr. Chair.
All right, Linda, go ahead.
Nick, I don't think anyone has said that it's a computer problem. It's a practice. It's approved. It's whatever. It's not a champs. It's not a right. They program that computer to do this and to their intent. And what gets lost in the discussion, and I really can't speak to the details right now, but that the consumers are impacted. It's not a straight benefit. It's either a different service or different entitlement to be transferred to that. So there's an impact to the consumer by putting them in this. In the Citizens Advisory Council meeting, the members were very upset about the idea that this would happen. And a lot of them are advocates, and they're seeing it happening to their consumers. So it's not just the money, it's the impact, and everything is the impact to the consumer by putting them in a program where they don't belong.
So if I continue on then, I want you to also, we all have equal responsibility here. The CFO has a responsibility to bring us a balanced budget, and the board has a responsibility to have an understanding of what that budget should look like and it also to be balanced. And so when you think about a $165 million budget, as you continue to manage all of the size of a PIHP and acute inpatient hospitalization and outpatient and CLS and all those services, 5% of that is $8 million. So, what is your margin of error? Don't have a margin of error, but just to put a figure to it, $8 million, more than $8 million is 5% of $165 million. So if you err and overspend 5%, as little as 5%, you're spending $8 million. If you err in underspend, now you've got that, $8 million. So that's one variable that's out there that we have to pay attention to. I really appreciate Lou's comment on the perception that maybe this is a good budget or not as good as we think it is. And that's why we all need to pay attention to it. I think it's a little bit more favorable than what Lou suggests, and Lou, could be right on many of those points as well too. The DAB is another variable. It's an independent variable. It's a lot of money. If we can get $4.1 million, I mean, that's quite a shot in the arm for our Medicaid. If we don't get that, the board needs to be aware of, and we're coming into a conference coming up, and you're going to see Bob Sheehan, and you're going to see Alan Bolter, and you're going to see other board members and CEOs, and you'll even see Linda Zeller there. So those who are coming to the conference here in May, there's not much more time, I think, to talk about the DAB migration issue. I think a little bit more than the budget coming out, because the budget's going to come out in, May or so. But the DAB migration may linger a little bit longer. By the time we get to the 2019 rates, we need to get this fixed. So we need retribution. We need monies back for what we lost in 16, 17, and what we're losing in 18. And then it's my understanding that Milliman will correct for some of the DAB losses in 2019. But we need to pay attention for 16, 17, 18 and not take this on the chin. That's a lot of money. And as a CFO trying to balance your budget, that $4.1 million is a lot. And then moving on, the legislative grant, I don't know where that is right now, other than, we talked about the $7.5 million. And the legislature just came back from recess, and I think the appropriations committees are wrapping up, if I'm not mistaken, and perhaps some of the recommendations are going to go into conference committee soon enough. At some point in time, we need to continue to be mindful, working with either GSI or the county executive. Where's our $7 million? Where's our? I hear about the roads, and I see lots of advertising, and I understand the county executive's position on repairing the roads. I don't know where we stand right now relative to the legislature having our attention on the $7.5 million. So I don't know if anybody has a comment on that. Again, I want you to see it from collectively our vantage point and from the CFO too. What $7.5 million would mean to our budget. Any comment on that?
Kathy?
The camera's not on me, so I guess I can talk, and hopefully, we had been working on that, and we did do something, and then we were told to let someone else take care of it. So that's I'm very frustrated. That's where I'm at. Very frustrated.
So am I. We signed the letter, we all okayed it. What happened?
What happened. The resolution was asked to go. It was the county executive's office and the lobbyist, the administrative liaison doing legislative affairs, asked for this board not to pass that resolution through to the Board of Commissioners to retract it. I'm just going to say retract it. And if there's going to be a recommendation or a request, as I understood it, that would go to the county executive's office, it would be through the legislative liaison in Maryland Lane and GCSI and their strategy. And so that's what this board did. This board pulled back that resolution that was sent to the Board of Commissioners, and now it's back in the hands of GCSI, strategy-wise, working with the county executive's office, the legislative administrator there, Maryland, on our interest. And I suspect maybe our interests are taking second to the roads. So as I had indicated to some that, all of our consumers live on a road. I don't know if there's a pothole in front of their house, but I know there's mental illness in all 11,000 of their homes. But we're for what that's worth. So I don't have a good answer for you. I'll follow up with. I put a phone call into Gary today. I didn't hear back from him yet. I'll follow up with Marilyn and Gary tomorrow and ask them what is the current status.
Can Marilyn come to the meeting and explain it to us? We don't want her.
I say we wait and hear what John hears back from them when he contacts them.
So I'll
First.
I'll contact him tomorrow and I'll send you an email. On just a sidebar note, I arranged a 30-minute conversation with Lieutenant Governor Kelly on Friday to also, indicate to him what's going on in Macomb County. So a couple of us may get on the phone with Kelly. Hopefully he has a listening ear. So that kind of wraps up that front section of number one here. Moving on to number two, we do have a financial risk management strategy, and you've seen it back at the December board meeting. We reviewed it, filed it away. It's time to look at it again. Part of not to compare Macomb County to Lakeshore, but we do have a board or a department-approved financial risk management strategy. And so I've brought it back out for your review again. And it speaks to the assurances for financial risk protection. It really speaks to the establishment of an ISF. The numbers are going to be different than the numbers that I presented to you tonight, because when we put the ISF together, that was back in December, okay? And so this is what we projected back in December, what we were going to have in the way of monies and what we needed in the way of monies. We really turned out a little bit better come February. So the numbers aren't going to match up in this first section on page 2 of the financial risk management strategy. But we're going to use, what we are using is ISF, the $10 million in ISF, and we continue to, engage in risk mitigation. How do we, the department gives us permission to do so and suggests that we do so. How do we engage in risk mitigation of our costs? So the most significant one is item 8 or 2A. That's the CLS supports. We've known all along that we need to do more in the way of utilization management and change some of our practices in the local community and with our families through community living supports utilization management. And we've done about as much as we can there. There's no more room or opportunity to proceed any further, any more aggressively than we already have on the community living supports utilization management. Number B is the utilization management for acute inpatient. I think we struggle there, and we need to be better if we really feel that there's going to have material value in reducing our acute inpatient hospitalization. We run about $14 million a year, and we shouldn't run that much. And it's trickling up a little bit, not trickling up, but it's creeping up a little bit. It was, I think, 14.1 3 years ago, then it was 14.2, 14.2. So we're running about $14.2 million in acute psych inpatient. And we feel that there's an avenue there for us through our utilization management practices to save a couple $1 million if we were really aggressive in being able to use some of these alternative services here, crisis stabilization, crisis residential, ACT, peer support services. But everybody has to be in on this. It's just not somebody else's challenge or someone else's problem. We need to have the hospitals working with us. They need to redirect those folks who need not be admitted. They need to work on progressive discharge planning. We need to work on diversions, crisis diversions, alternative diversions. We need to work on continuing to build on the UBHC. And if we're successful in that regard, ideally if we could pick up, a couple $1 million on acute psychiatric inpatient cost. So that was number 2 in our in our risk management strategy. Item C is provider network reimbursement rates. As the board approved here, a year ago or two, that we're going to hold the providers at 2015 reimbursement rates. So we're moving into a 2019 contract period, at the end of the fall here, and we're still doing with 2015 rates. That we are going to have a few challenges. I think next month I'm going to bring to you a couple recommendations to actually provide providers with an increase, and I'm going to explain why that's necessary, but I'm not certain we have the money to do so. So I guess it'll be an interesting discussion to the board if we are not certain we have the money to do so, and what's at risk if we don't increase some of those providers. A couple of them are going to come before the board, and I'll explain them next month when they come in May.
Kathy?
Back to the inpatient issue. Do we have data on how people get to the hospital? How they get there? Is that part of what we know? Is like, do the police bring them there? Does family bring them there? Do they self-admit?
I don't think we have that data. I would have to check with my staff to see if in the certificate of need document that they fill out where they came from. I guess that my belief would be no, we don't have that data.
Okay, because I don't know if we can get that, but that seems like that could be a way to help problem solve, to know who to educate in terms of that.
Right. Okay, good point.
Thank you.
Then item D, it is what it is. We talked about soft hiring practices. The board didn't want to do a hiring freeze, and so we haven't froze any positions. But I'll be real transparent with you here that we have 80 vacant positions. 25 of those positions, and they're of all sorts. 25 of those positions are administrative. 55 are union and non-union and contract positions that we used to usually practice with, and we're not filling them right now. We have lots of positions that are posted. We post all the time, but you've been able to give me the discretion at this point in time, or the chief of staff, the discretion on what positions we need to refill and what positions that we don't refill. And the importance of this, when you think about it, if the average position, we'll just say, costs $67,000 a year with benefits, clerical or someone who gets paid higher than administrative. Let's just say the average, I don't know what it is. Let's say the average is $67,000. And if you have 10 vacant positions, that's $670,000, okay? And if you're $40 million in the hole, you're still $39 million plus in the hole. If you have 100 vacant positions, that's $6.7 million. You're still $32 million in the hole. And so the point to be made here is that we're working through utilization management of CLS. We're working through utilization management of acute inpatient, and even 80 vacant positions. Not that we want 80 vacant positions, but there's a lot of money behind that number of positions that we have, and it compromises our administrative capacity. We're still good with our contract. That's the main thing, not lose sight of retaining the integrity of the PIHP contract. But a lot of the staff are doing added duties administratively because we just can't afford to replace some of those positions. Same with the contractors, some of the union and non-union positions too. We just, have a challenge, but we continue to fight through it to do everything that we can to try to, balance our budget, and that's what it's taken so far. So the CLS utilization, acute inpatient utilization, freezing the provider rates, and our staffing is still down right now. At some point in time, I would like to think maybe by the end of the year, if we can come out a little bit more financially solvent, and I hope that's where we'll be, then we can start bringing those positions back online. But right now, I think everybody is concerned about the absence of being able to hire positions and keep all of those positions full. Some of them we don't do. We haven't laid anybody off, and I don't want to be defensive here, and I'm not going to take that position. I think we've been real progressive. We haven't caused a pink slip. Now, there's never been a pink slip in community mental health since I've been around for 33 years as an employee. You know, we're not Allegan County. Allegan County laid off 120 people. And I don't know how you do that. I don't know how you do it. What do you do with all the administrative functions and all the consumers you need to treat if you just tomorrow lay off 120 people? It'd be helter-skelter. So we've been able to keep the system running. I think we continue to meet all of our performance metrics through the department, and I hope that we're at the end of this, that we don't have to go too much further. So that was part of that strategic plan that the board had approved. And then in the second paragraph there, we do continue to improve on and strengthen the CMHSPs. You know, we mentioned here before, even though the SRS got some attention because we were moving some folks around, we only moved 5 of 300 people around. But we've strengthened the CMHSPs. We got a fetal alcohol syndrome disorder cohort award, and that's going to bring on more staff and strengthen our CMHSP. The staff went out and got a community block grant for adult crisis stabilization or adult community outreach. They got a block grant for children's community outreach. We just got certified for children's crisis residential services. All that requires more staff. And then there was 3 other ones that we just recently received that I can't even speak to tonight on relative to information technology. So we are growing and we're expanding. And when we do that, all of the ones that I spoke about, the FASD, the children and the adult, we're doing that all internally. You know, we're not having someone else do that. That would be our prerogative, you know, to say, well, here, we'll just have you go do it, have another agency go doing it. We're doing it internally. So we're a lot of growth. I think the children's division, I went out and presented to that group. I think there's 65 employees running our children's program. It's an amazing group to see, not to, take issue with them relative to any other program that we have, but to meet that group of young, and mostly young, professionals new into the system, contractors and full-time employees alike, just amazing the amount of work that they do. And I understand that they're taking on between 10 and 15 referrals a week, children's. There's so many children's cases that they do. And I think we should have a lot of pride in that children's program too. So we maintain status quo with the financial risk management strategy. So this is keeping us apart from someone like what's going on in Lakeshore. No, don't expect to bring to you any requests for staff layoffs, nothing like that. I don't expect the CMHSP to go away. I've been going around trying to meet with the staff. I've been to 5 or 6 staff meetings, at one today, explaining some of the strategic plan that's going on. Continue to maintain the PHP contract. That's your prize. Don't lose that. That pays 98% of everybody's salary, and all the services that are out there are through Medicaid, the CMHSP contract and the MyHealthLink contracts. Those are your revenue sources, and that's your chore and your task. So I've been going around, and I think the staff are generally receptive, having a better understanding of what's going on. But I don't expect any unsettledness with the community mental health services program. PHP, we'll keep working on that. Any questions? So then moving on, I don't know if I probably won't speak much to it.
Go ahead. Hold on, John. Go ahead, Lou.
I was just having a bell ring when you were mentioning the vacancies. Doesn't the contract require a posting of a vacancy?
It requires a posting of the vacancy, and there's also a reference to that document that was signed a long time ago, contingent upon the availability of local, state, and Medicaid dollars.
I'm talking about the general contract, not the amendment. You just quoted the amendment.
Yeah.
I'm talking about the contract that requires the county to post union vacancies within a 30-day period. So technically, a further complication is we're in violation of the contract. No, that was just for certain jobs. That amendment just applied to certain jobs, not to the general contract. Does it require posting for vacancies? Okay. Okay, I'm corrected. The question is, you're required to post, but you're not required to hire.
They don't have to post it.
Okay. Okay, I just wanted to be sure we didn't have another bomb out there.
You also have my promise as well too. There's a little variance there, not much. A couple of staff here or there because there's so many people that are moving all the time. You have people leaving and coming and going. But we use contractors and we use full-time employees, but we do not use contractors to replace full-time employees. We've never done that. I've never done that. We have a roster of contractors that we've had, and if some of those contractors go, we may or may not refill those contract positions. And then a lot of them are full-time employees. Sometimes we may or may not replace those positions depending on the necessity. But what we do not do is take a full-time position and replace it with a contractor. I've never done that. So I really appreciate a chief of staff, I'll tell you that, because it is a full-time job trying to manage the network, and I really have an awful lot of appreciation for the work that she does, chief of staff. Item number 3, I don't know how much you want to go into this. I provided the letter to you tonight. That was actually the letter that the department sent to Lakeshore Regional Entity. I don't know if it's probably the best practice to speak publicly about what's going on with them. And I also some newspaper articles. I won't speak at all about those. It's just newsprint as far as the factualness of it. But the issues that the department has with the Lakeshore Regional Entity, far and away, is the risk management strategy. I talked about that last week. The department was willing to meet with the PHPs. We meet with them the first Thursday of every month, and they had a discussion, and that is the sticking point, is the internal services fund, the ISF, in the financial risk management strategy, that they haven't been able to sew that together and continue to show their financial solvency forward. That's why we have to pay attention to what ours is. They don't have one. They don't have one that they can produce an ISF, and they don't have a financial risk management strategy. That is the straw that's going to break the camel's back, I'm afraid, for those folks. Governance, they also have an issue with governance. I don't know why they don't have an issue with governance in Macomb County, in Wayne and Oakland. There used to be 10 board members. Lakeshore Regional Entity has, I think, 7 counties, and there's 5 CMHSPs. A couple of the counties are married together. So there's 5 community mental health services programs. 2 board members from each community mental health services program sat on the Lakeshore PIHP board. And that was a 10-member PIHP board. And then back when Beacon, if you guys remember the Beacon report, when they went in and looked at Lakeshore, said you need to expand your governance. And so they added on, I believe, 5 more positions, 5 or 6 more PIHP positions. But then the PIHP formed an executive board of the PIHP made up of 1 person from each of the 5 CMHSPs. So they continue to control their own self-interest. The CMHSP representatives who sat on that PIHP continued to control the self-interest of each of the CMHSPs. And I think that's where the department, you read that letter, it kind of says to that they have to continue to realign their governance. And this board, you sit here, in a good situation and a bad situation, because you have to protect the PIHP and you also protect the CMHSP. So, if they're calling out, Lakeshore, I don't know why they wouldn't call out anybody else, because they're all set up similarly. So, Region 10 is set up the same. You have board members from the CMHSP that sit on the PIHP, and they have an interest. I don't know how they're going to fix their governance thing. Managed care functions, A lot of it's utilization management and utilization management practices that are consistent across the network. Many of the CMHSPs do not know how to engage in utilization management practices, and they're not consistent across the 10 CMHSPs. They don't have it figured out. Our utilization management practice is really a PIHP function, and so we're just in a nice situation that affects the whole county, and we're good with that. There's such variance throughout the other regions that I think there's a lot of public and stakeholders that are concerned that in one county you get this, another county you get this, and the utilization management practices are askew. That's a problem. Data accuracy, I don't know much about that other than it doesn't sound like they're meeting the mark relative to their encounter reporting and their monk reporting. There are so many electronic reports that go to the department. It's kind of incredible. And then the last thing is ongoing communication. I'm not really certain what that's about other than if the PIHP board brings in someone else, because they let an RFI or an RFP out to have somebody else come in and manage that. If the PIHP board brings somebody else in, they want ongoing communication. So that's the nuts and the bolts of where Lakeshore Regional Entity is. The department, they have to submit their proposal, their plan of correction by April 22nd. And I would think in very short order, the department's either going to say, okay, you're going to continue, or they will terminate their contract on October 30th for a material default. And that's what that letter says. And when you read the letter, it reads pretty stiff. And so,
Sorry, John.
Go
You
ahead.
ready for a question?
Thank you, John. I have just a couple questions. So you just talked about the fact that they were cited here for their utilization practices, right? So what happened to this organization as a result of the Milliman report? Like, we got cut severely for it. What happened to them? If their data, if their utilization practices are not in order and they didn't comply, or they're whatever, what happened to them? I mean, we lost how many millions, and what happened to them?
well, I think I think a matter of the monies, where the monies flow relative to the Milliman actuary, and what the actuary comes up with, and what consumers need in the way of services is different than what is as a utilization management practice. And just by example, treatment prevalence factor. You know, if there's a consumer's, the actual definition of treatment prevalence factor, that's one of the factors that's used in rate setting. And before, it was historical trends. If you got money before and you used the money, you purchased the services, then it was indicative that you were going to purchase more services in subsequent years. And now they use different factors. There's a number of factors that they use: geographic factors, treatment prevalence factors, age, disability, chronicity, those types of things. So the Milliman report, I don't know if I'm answering your question, but the Milliman report would be based on all of the utilization factors and related decimal points on how rates are driven and what they actually practice in the way of utilization management. They don't look at treatment prevalence factor, and they look at the person-centered plan, and they look at the consumer's need for services, and then they make decisions on medical necessity. They wouldn't make a decision based on age or gender, because those are two different factors as well too on how we get paid. Follow me?
I do, but I thought that the actuary report talked about, and our subsequent report that we got a couple months ago, I can't remember the name of it, but kind of laid out the fact that supposedly we were providing a higher level of service than other counties, right?
Right.
Based on data, right? And based on all those things that you just mentioned, right? And yet I'm looking at this report and I'm saying their data's out of order, their distribution of services is not proper. And my question is, so what, the net result to us in the Milliman report was we got a huge budget cut. My question is if their data was all out of order and their utilization practices were all out of order, What happened to them in that Milliman report? Are we, I mean, I don't know. I'm just, and the reason, and I'm going somewhere with this, because, you know, the department has issued this letter saying they're gonna take over that, you know, that group, or basically, you know, assume their contracts. I don't know what, they're gonna redistribute the services. Yet I'm looking at this budget, general fund distribution, and that whole region that this area represents are all on the plus side of this redistribution of money. So they're a struggling system that doesn't function well, that doesn't manage their utilization and doesn't manage their data. I don't know what happened to them in the as a result of the Milliman report. Now I'm looking at this general fund distribution list, and I see that, ironically, this was released when this was released last month, right? This redistribution of this general fund, where we're going to take yet another cut, and this one that is potentially being taken over is one of them. One of the seats is getting 193% increase. Now their budget is much smaller than ours, but it's a huge bump. Another one's getting 139%. So I'm trying to understand the motivation of the department, right? I mean, are they just posturing for a takeover and then they're going to funnel a bunch of money there to make themselves look better? I mean, I don't know. What is going on?
I think,
And are we next, I guess is my next question. I'm sorry, but that's what I feel like.
Go ahead, Lou.
Susan, you're exactly right. The Milliman report indicated that we were delivering services higher than the average. The follow-up report that I had exception with a couple of meetings ago did not substantiate the fact that we were delivering services beyond what other similar PIHPs were delivering. So
Agreed.
that's the bigger joke.
Right, I agree
The
with
next one is that Network 180, which is Grand Rapids, which is just north of Holland, recently closed down some service opportunities to consumers, and subject to correction, laid off 180 of their employees. So the next fireball after Holland is Network 180, and Network 180 was picked by the legislature to provide a single opportunity with the physical health care people as a special situation, John, am I correct? So they're on the edge of shutting down, and Network 180 has been getting money that we've been losing all along. So put that together for where you are. The Milliman report, the state used to cut us. You're never going to figure out what their motives are because they bounce around too much. And the follow-up report, which the state paid for, supported the fact that we were not providing services out of context. Did they make any adjustment to the cut? Of course not. So how do you understand this when, as I said, Network 180 shut down several services, buildings, and laid off, I believe, 180 employees, subject to correction, but that's what I picked up. I may be off, but that's an awful lot of people to lay off when you're set to go forward to be one of the primary tests that the legislature's approved with the physical health care people. So more to come, Susan, you're exactly right. But if you try and figure it out, you'll go crazy.
Well, I mean, I just look at this, and I don't pretend to understand all the details with Lakeshore. I mean, I know that it's been struggling for various reasons over time, and I don't pretend to know all of their business. I can hardly keep up with ours. But it just seems to me like we're just on a track here, and all of this effort that's being expended to engage our lobbyist to ask for money from a staff person from our own county. It seems ridiculous. Like, I feel like we're just spinning our wheels, and it doesn't, when I feel like it's just a matter of where we are on the target list from the state. And I'm just trying to assess what the end goal is. So.
I think that just be my subjective opinion, hanging out with the peers that I hang out with, the CEOs, they're a little frustrated and concerned with what the true intent of the department is. It doesn't sound like they want to work with LRE any longer. They don't want to fix the DAB migration issue that's going on. They understand that all of us, all the PIHPs are struggling in being able to retain and accrue ISF, and the general perception is that they're just putting a chokehold on you, trying to force you out of the business. I don't think that my opinion is that if the system of care is going to change, it's going to change with a new governor and the new legislature next year, and that if there's any effort towards privatization, it's not going to be 298 that's going to affect privatization. That's just, a product that's out there for a few years. I think the threat is greater. I think the lobbyists mentioned it in the Metro Region dinner meeting. I think the lobbyists for the HMOs are still out there, doing education and working with the legislature and the incumbents and the new folks to indicate that that they still want the control of the behavioral health funds. And I think the PIHPs are going to go away. Most of my peers think the PIHPs are going to go away. CMHSPs will be here. They'll be well and good. And as far as Macomb, you got to give just $1 million, not $1 million, let's not use money, a ton of credit to the administrator, to the staff, to the executive staff. They stand here and propose things to you during board meetings, and none of them sit with their feet up on their desk. And they're doing double duty. They work hard from morning till night, and it's the administrative staff in Macomb County that has made this work. And I'm not saying myself, I'm saying Jim and everyone that's in the audience and most of the folks that aren't here. Those are the ones that make it work, and those are the ones that have continued to make Macomb County viable as it is. I don't know what happened in Lakeshore, but we're not going to be next. We're not going to be next.
Okay. So, I'm happy to hear that we're not going to be next, and I too credit the staff for a lot, for all their efforts. They do. I know they've got a heavy lift, and I know that even reevaluating all the cases of the, community living supports and stuff, that was a very difficult thing to do. I know that. And people aren't in these jobs for the money. They're in these jobs because they care about people, and I know that. So it makes the budget cuts even harder to stomach, right? And so I'm looking at this, and I'm really trying to get vision or line of sight on the end goal so that we can navigate away from it or around it. I feel like right now we're just putting out all these little fires as they pop up, and we're really losing sight of the end goal. And maybe, Lou, when you spoke about all the laid off employees, maybe that was just a union busting tactic. Were those unionized employees?
I don't know the classification. I just saw the number.
Yeah. I don't know if it is on the west side of the state or not, but I'm just trying to get your opinion of what the long-term objective is, and maybe thinking about this differently, thinking about their long-term objective, thinking about their potential steps to get there, their timeline to get there, who's next. It might be some questions to ask, and think about how we, get ourselves further down the list in order to make sure that we're still alive when the leadership changes, right? I don't know.
Well, there's a lot of moving parts in that. I think you need to we're going to get a PHP contract. Staff are negotiating that contract right now with the department. That'll be issued earlier than it typically is. It's going to be issued electronically, and it's going to come out a couple months earlier than September, I believe. We're going to sign that contract, and so we got a PHP contract from now until September 30th of 2019. And, we know that's going to be the case. And we'll also get a community mental health services contract as well. I think we need to continue, as I've said here, as much as we respect ourselves as a community mental health services program, we also need to be, experts at doing healthcare administration and all the things that go with it. And, as close as we can get to, and I'll say it over and over, and I have said it over and over, that we provide nothing more than medical necessity, nothing less than medical necessity, because that's our charge, and only based on one's benefit plan. So if you're Medicaid, you got to be really good. Caseworkers got to be good. Access centers got to be good. Grievances and appeals and everybody's got to be good. That we provide nothing more or less than medically necessary. You get what you're supposed to get. And that's how you contain your costs. And that's how you provide services to consumers. It's not about cost containment. It's about providing the right service to the consumer, and only based on one's benefit plan. If you have Medicaid, you have Medicaid. If you have general fund, you don't get a Medicaid benefit. And if we do that and continue to do that, we will find ourselves in a much better situation, and I think we've been doing that in a much better situation as far as financial solvency of the PHPs. What the state ever does with the PHPs, I think that's out of our control. We just continue to be the best we can as long as the state continues to issue a contract to us. I mean, we're not going to give up our contract. If the state goes a different direction, I don't have a crystal ball on that one.
Okay, thank you.
Lou? And then Nick?
I have personally come to the conclusion that the State Department's strategy is that PIHP failure is good, because I think they would like to accumulate a number of PIHPs that fail, and they're going to use that as a foundation when they're presenting to the legislature that privatization is the substitute, because if they can do that, the State Department will reduce the mental health employees down to about a dozen, and their sole job will be to supervise the contracts with the privatized providers. And they're going to say that these providers shall contract with the CMHSPs. That's going to be the bone to ease the privatization move by the state. And the healthcare organizations will, within 2 years after that shall, find a way around, and the CMHSPs will follow where the PIHPs have gone. Now that's what I see happening in the state of Michigan, because if PIHP failure was not on their agenda, they would not be doing what's happening in Lakeshore and what's happening at Network 180, and frankly, cutting us $41 million within a year and a half is a ridiculous way to adjust your budget. Nobody does something like that instantly. If you're going to make adjustments, and the follow-up report did not substantiate the Milliman strategy for the initial cut to that service. So I'm saying the footprints are in the sand. This is exactly where I see them headed. And frankly, the more failure that occurs as you go downstream, I think is supporting where they want to go. Because if you will report or remember, Nick Lyon wrote Governor Snyder's original proposition to privatize the program that was defeated 2 years ago. And he admitted that at a session at one of the conferences, that he wrote that what was it, 128, or was that thing in the budget where the governor proposed instantly privatizing the whole system? And Nick Lyon is the head of the mental health program, and I don't think that momentum or strategy has changed. I mean, there it is. He wrote it for the governor, and the state association and its allies managed to overcome it. But as John mentioned, they are still working, and by that I mean the healthcare organizations are working like gangbusters with the legislature, and I think the State Department is supporting it also under the radar. That's my opinion. I think that's what's going to happen. So,
Nick?
Yeah, it's kind of fruitless to try to figure out where the department wants to go. For one thing, it's going to be a different department next year, right? Because of term limits. Well, because of term limits, there'll be a different governor, and that governor may be more friendly, may be less friendly, may have a different department. We don't know. I don't make predictions on elections. I learned not to do that a long time ago. But I did see, and I do agree with you, John, that the 298 thing is pretty much a dead approach at this point. For one thing, even on the pilot programs, they have a million different obstacles they have to go through with the federal government that they haven't started yet. And even on those pilot programs, they ran into a new snag just last week with the residual fee-for-service population. So they're in a total mess over there trying to figure out how to meet even the minimal requirements of Section 298, and to do that by the end of the year, I think, is highly unlikely. And I think that's to a great deal thanks to the advocacy of the CMHs, of our state association, of everybody here, of the advocacy groups in particular who've done a whole lot of work on this, and a lot of other people. On the House budget for the coming year, however, I just noticed that you passed out Alan Bolton's analysis of the House subcommittee, and I don't see anything in there on the DAB issue, which is a concern. But I do see something that caught my eye that said, at least in the House version, and it's something we should probably try to fight for, that would hold harmless CMHs that would be negatively impacted by the new funding formula, GF funding formula, which, again, I have serious problems with the GF funding formula, period, but at least buying that extra year and holding us harmless would be beneficial, would be a benefit, and that's something I think we want to kind of lob on to along the way. But, and just one other thing, Susan's concern about the utilization rate, where we did get dinged in the Milliman report, but the real loss of money there was the exclusion of the historical context piece from the formula, and that really is what cost us even more money than the utilization issue.
Right. Nobody talks about Medicaid redistribution anymore except for ourselves in Macomb County. We still talk about it because we were hurt by it, but you know, that was the catalyst behind, you know, 50% of our funds was based on prior utilization as a predictor for future utilization. And when they took that out, there went your money. And so it is what it is. The last thing I wanted to talk about, I guess I'm really not going to say much, Nick talked about a little bit, was the general fund, Medicaid general fund redistribution over the 5-year plan. And so I passed that out last year. You know, we're doing all right now on our general fund. The one thing that's getting attention is the spend downs. And again, you know, it doesn't hurt to continue to repeat it so everybody understands it really thoroughly, that whether it's in Macomb County or in Colorado or California, some county there, once you meet your Medicaid spend down, then you are eligible for Medicaid. And historically, we had lots of general fund dollars, and we would help consumers. If they were at a skill building program, by example, and it costs $89 a day for that, we would pay for that. We would pay for that out of our general fund and then allow them to go to skill building, because it paid for their spend down. We don't do that anymore. We don't have the money. We don't do it. And that's left a lot of our consumers challenged, that they don't have supports. We have very few consumers that we have to continue to support with general fund dollars on spend down. And if a consumer historically went to a skill building program and now they're no longer in a skill building, they have to go back to their group home all day long. That doesn't really support the waiver, because we want the more community included. But at the same point in time, I'm not paying the provider any more money to watch the consumer all day. I already pay them 2 per diems as it is. And so that's creating some challenge with our providers too. You get a personal care per diem being in a group home, pay you for personal care, pay you for CLS. And it just so happens that now that your consumer's in the home all day, I'm paying you 2 per diems. Always have paid you 2 per diems. Not our responsibility to pay them added dollars to their group homes. And you have those types of things that are coming up, and I'm surprised there aren't more public here, because my phone rings quite a little bit, and I'm sure everybody else's phone is ringing, that the consumers are concerned that they've always been able to send their son or daughter or ward to skill build program, and they can't do that now until day 9 when the spend down is met someplace else. Now they can go back because Medicaid's active. But you have to provide medical necessity based on that benefit, and that general fund benefit does not offer skill building. It offers emergency crisis hospital services. So I think it was good tonight to be able to review this and to talk about it again and refresh ourselves. I look forward to the report that comes out in June. Optimistic that we'll continue to be financially viable here, and also do what's in the best interest of our consumers too.
Thanks for the report, John. Are there any other items from any other board members? Joan?
Before we close, remember I mentioned about going to see Sacred Heart. If anybody wants to go. I know Linda and I are going the 17th, and we're going to meet at 10 o'clock at the ad building. Now, this will not be one of our meetings. You will not get a per diem, and will not be counted as if you don't go. So, right? So we all understand that. So if you want to go, let me know so we can give a count to Sacred Heart. That's it.
Thanks, Joan. Anyone else? All right, seeing none, we'll move on to hearing of the public. Anybody from the public? Going once, going twice. Everybody's out enjoying the warm weather. All right, we'll close hearing of the public. With that, I'll take a motion to adjourn. Motion from Kathy, support from Susan. All in favor signify by saying aye. All opposed? All right, we are adjourned. Have a good night, everybody.